Should I start?
Yes, please. Thank you.
Hello. Let's start with name of Allah. Bismillah ar-Rahman ar-Rahim. Sorry for being late, as my lecture was had to start it at 10:20, but as I recently joined DHU as an assistant professor of cardiology, so it took me some time to get to the place where I had my lecture. So let's start to our topic. The topic given to me for today's presentation is approach to a patient with chest pain. Before starting my presentation, let's pay tribute to our Unsung heroes who sacrificed their life for serving his nationals in this pandemic. Learning objectives for today's presentation is to develop a differential diagnosis for the chest pain, differentiate life-threatening causes of chest pain, and formulate diagnostic approach using history, physical examination, and important tests. Unfortunately, we don't have health structure, so we don't have true data. But in epidemiology of the chest pain, this data has been taken from US, in which it says that annually 5 million emergency department visits with chest pain. In that, 2 million gets hospitalized annually with the cost of more than 8 billion. Cardiac etiology is found to be less than one third, and 2% of patients with acute MI are unrecognized and discharged from ED department. Before starting our true topic, let's go over with anatomy, as we used to study 2 years in our medical school anatomy, which has great importance while approaching the patient and to get to your diagnosis. So whatever we have in chest can be the cause of the chest pain. As you can see from anterior to posterior, this is the lateral dissected view of human, in which you can see the thoracic as well as abdominal organ. From anterior to posterior, you can see the skin, then musculoskeletal tissue, then the precordium, heart, and great arteries. Posteriorly, it lies on spine. So disturbance or disease of any of these organs can present with the chest pain. While I was preparing for this lecture, I came to know that there are thousands of causes of the chest pain. But this is the beauty of internist, or this is the beauty of your profession, to get to diagnosis within minutes or within hours of presenting an emergency, because it may be one of the life-threatening cause and it may be very troubleshooting. So keeping that diagram in your mind, you can have differential of the chest pain. So it can be due to cardiovascular cause, due to pulmonary cause, due to GI cause, due to musculoskeletal cause, or miscellaneous. While paying attention to cardiovascular in left of your screen, left side of your screen, that it can be due to involvement of the pericardium, it can be due to involvement of myocardium, then endocardium, which encompasses of valves, then conductive system, and vessels. So in pericardium, inflammation of the pericardium, that pericarditis may lead to chest pain. And in myocardium, myocarditis, exacerbation of heart failure or hypertrophic cardiomyopathy or Takotsubo cardiomyopathy can lead to chest pain. Heart valves, mainly aortic stenosis, can lead to chest pain. And conductive system directly doesn't cause chest pain, but tachyarrhythmias that lead to chest pain due to increased demand of oxygen or increased demand of supply. that may lead to chest pain, that is supraventricular tachycardia or ventricular tachycardia, may lead to chest pain. And vessels, the most common or the most life-threatening causes, that is acute coronary syndrome, which comprises of ST elevation MI, non-ST elevation MI, or unstable angina. That is one of the important cause of the chest pain. And aortic dissection. And aortic dissection is also one of the life-threatening cause of the chest pain that need to be diagnosed immediately and take prompt action to save the life. And hypertensive emergency may lead to chest pain. While coming to the lung pathology or lungs or pulmonary system, involvement of the pleura, that is pleuritis, may lead to chest pain. Pneumothorax is one of the very important cause of the chest pain, that is life-threatening condition. And airways, involvement of the airways, that is acute exacerbation of asthma, may lead to chest pain. Involvement of alveoli, pneumonia, can lead to chest pain. And vessels, that is pulmonary embolism or pulmonary hypertension, may lead to chest pain. Lung cancer rarely cause chest pain, but it may lead to chest pain due to organ compression, and other viscerous compression may lead to chest pain. While coming to GI system, esophagus, involvement of the esophagus may lead to chest pain, that is GERD, esophagitis, esophageal spasm may lead to chest pain. Stomach pathology mainly causes abdominal pain, but it can lead to chest pain. The important causes are gastritis, peptic ulcer disease. Most of the percentage of the acute coronary syndrome that is being missed or discharged without getting treatment is misdiagnosed as gastritis. So in musculoskeletal system, ribs fracture can lead to chest pain and costochondritis. Other causes of the chest pain are severe anemia that lead to organ deficiency of oxygen, herpes zoster, dermal involvement of the shingles, or intoxication with cocaine or amphetamine, acute chest syndrome in sickle cell anemia, and psychiatric pathology can also lead to chest pain, that is panic attack or somatization. While, as I said, there are hundreds of causes of chest pain, but while performing duty in emergency department, it is our duty to get familiar with life-threatening causes of the chest pain. We have to diagnose that disease who has to be diagnosed immediately and should be taken prompt action to save their lives. So out of all those diseases, I selected the 6 deadly causes of the chest pain, and we will go through most of them in upcoming slides. So the most common is acute coronary syndrome, which comprises of ST elevation MI, non-ST elevation MI, and unstable angina, as I discussed previously. Then aortic dissection. In aortic dissection, what it does, there is a flap in the great artery, which may lead to chest pain. And if it descends downward, it can involve the aortic valve and may lead to AR. While if it extends superiorly and involve the great arteries, that is carotid arteries, it may lead to stroke. And then pulmonary embolism, it's one of the deadly causes of the chest pain. Then pneumothorax, it is very instantaneous and very catastrophic condition if immediate action is not taken. Other causes are esophageal perforation, and pneumonia can lead to chest pain, and this is also a serious disease. But we will go through the first 4 causes of the chest pain. Before going to the algorithm of the chest pain, we have to be very familiar with the history of chest pain and important characteristics of the chest pain, that either it is exertional or it is relieved by rest or not, or is it disconnect? Uh, Before going to the algorithm of the chest pain, we have to see all these four things in our history. That either it is the chest pain is exertional, or is it positional, or is it pleuritic or radiation. These four things lead you to your diagnosis, and further your important tests will endorse your diagnosis. So how to approach to the patient with chest pain? These two tools leads to your diagnosis in 90% of time. If you take proper history and do your proper examination, you hardly need anything else. You just need your very common tool to endorse your diagnosis, that is easily available in every emergency department, that is chest x-ray and ECG. Then further, by endorsement of your these investigation tool, that guide you what's next best step for this patient who presented to you with the chest pain. So let's go one by one with four deadly causes of chest pain. The first I choose is acute coronary syndrome. So in history, what you find in acute coronary syndrome, that is onset over minutes, and it is substernal or midline. It is exertional and relieved by rest. It is non-pleuritic. The chest pain is like pressure-like tightness in the chest, and usually it radiates to jaw or either arms. It is being said that any pain from umbilicus till earlobe or from earlobe till umbilicus may be cardiac or may be due to acute coronary syndrome. The risk factors are for acute coronary syndrome are diabetes mellitus, hypertension, smoking, hyperlipidemia, obesity, and family history. If you find in your history any of these things, that will further endorse your diagnosis. What you get in examination of acute coronary syndrome usually often normal, but you may find S3, high JVP if patient develop failure or chest cramps. About 5 to 10% of patients present with acute coronary syndrome with shocks. That is, blood pressure is lower than 90 systolic and lower than 60 diastolic. Chest X-ray usually normal. What you find in ECG is either dynamic STT changes, that STT changes with chest pain, and ST elevation, ST depression, or it can be normal. It is from American College of Cardiology, ACC, and AHA recommendation, American Heart Association recommendation, that when the patients arrive in ER with the chest pain, within 10 minutes of arrival, ECG should be done. If ECG doesn't help you, or it showed to be normal, then you repeat ECG or do serial ECG after 10 to 15 minutes. That may lead to your diagnosis. This is an ECG of a patient who presented with the chest pain. You can see sinus tachycardia with normal axis, and there is ST elevation from lead V2 to V6 and lead 1 and AVL. And there is reciprocal changes in lead 3 and AVF. So the diagnosis is extensive anterior wall MI. What should be done next? This patient should be referred to cath lab and shift to cath lab emergently within 30 minutes of its arrival to ER. This is another ECG of a patient who presented with chest pain. And you can see sinus tachycardia with normal axis, and there is ST depression in lead 2, lead 3, AVF, and T wave inversion in lead AVL. And also there is ST depression in lead V3 to V6. So this is non-ST elevation MI. What need to be done is do troponin and start your medical treatment. So having chest X-ray, history examination, chest X-ray, and ECG, these will guide you what should be done for this patient. If it is ST elevation MI, shift the patient to cath lab immediately. And if the ECG doesn't show ST elevation MI, it shows ST depression, do cardiac enzyme to diagnose is either non-ST elevation MI or unstable angina. If the troponin raised, so it is non-ST elevation MI. If the troponin comes to be normal, so this is unstable angina. But the treatment line for both of these are same. And if the ECG showed to be normal, then repeat ECG, do serial ECG every 10 to 15 minutes. Next entity is pulmonary embolism. What you get in history, onsets over seconds to minutes. It is instantaneous. It lateralizes to one side. It is non-exertional. The pain nature is sharp or pleuritic. This pain doesn't radiate anywhere. The risk factor for this diagnosis is hypercoagulable state of various causes. It may be due to recent hospitalization, immobilization, or malignancy. These all lead to hypercoagulable state that lead to DVT or stasis or thrombus form anywhere in your body, and then go to your lung and obstruct great arteries of lung. What you get in examination, evidence of DVT, right-sided S3 or RV heave in some patient. Chest X-ray or ECG is usually, chest X-ray is usually normal in this condition, while you get, most of the time you get sinus tachycardia in pulmonary embolism. But in some entity of patients, you get S1Q3T3, which is more sensitive and more specific. If you get S1Q3T3, then your diagnosis is confirmed and you need to start your treatment. This is the ECG of the patient who presented with chest pain, and within 10 minutes of his arrival, ECG is done, which showed S1 in lead S wave in lead in lead 1, and Q wave and T wave inversion in lead 3. And the other important finding is sinus tachycardia. You can see the rate is about 120 beats per minute. So having all these tools, if your clinical suspicion is low and you think that it is least likely to have pulmonary embolism, then do D-dimer. What D-dimer does, if D-dimer comes to be negative, not raised, then it is your pulmonary embolism diagnosis is excluded. One of the life-threatening cause of chest pain is excluded, so you have to relax. If the clinical suspicion is high, then start treatment. You should start treatment in emergency department and plan for your CT scan. Take a radiologist on board and do CT scan, but don't delay your treatment. Don't delay your treatment for CT scan. You have to start. If the clinical suspicion is high and you get ECG findings and treat, then you should start your treatment before having CT scan. The other important cause of chest pain is pneumothorax. The onset of it over seconds. It also lateralizes to one side. It is non-exertional. The chest pain is pleuritic that changes with respiration. It is sharp pain, and it also doesn't radiate anywhere. The risk factors you can have with this disease is COPD or cystic fibrosis, but it is not necessarily. Acute trauma can lead to pneumothorax. pneumothorax, or fracture of the ribs can lead to pneumothorax. In examination, what you get is unilateral absent or diminished breath sounds, unilateral hyperresonance on percussion. ECG is usually normal in this patient, except you can have sinus tachycardia, but otherwise it is non-specific. Non-specific findings you will get in ECG, while chest X-ray showed pneumothorax. This is a chest X-ray of the patient with pneumothorax. You can see on your left side of the screen that there is hyperlucence lungs with absent lung field, jet blackening of the lung shadow. That is, and while in left side you can see there is lung shadow. So additional diagnostic workup is usually not necessarily in case of pneumothorax or tension pneumothorax. It is very rapidly progressing, life-threatening condition. You need to emergently involve the concerned team, that is thoracic surgery department, for decompression of lung. Aortic dissection, the last entity that you will get history. The onset of the pain is seconds to minute. It is substernal midline, non-exertional. It is non-pleuritic, but it is like tearing pain that starts from anterior and goes to posterior chest. The radiation is to back. What you get in risk factors are hypertension and smoking. Connective tissue disorder is also another risk factors that is associated with aortic dissection. The examination is usually unremarkable, but what you can have is high blood pressure or brachial pressure. Blood pressure may be unequal in both arms. ECG is usually non-specific findings. ECG doesn't show any specific finding. While in chest X-ray, you get widened mediastinum. This is the chest X-ray of the patient with aortic dissection. That you can see clearly that the superior mediastinum is wide. You can clearly see the cardiac slit separately from the another hyperdense areas, which is the aorta, shows aortic borders. What need to be done after your history examination and the chest X-ray? If the patient is clinically stable, to confirm your diagnosis, you need CT scan. But if the patient is clinically unstable, you should do the transesophageal echocardiography on bedside. And if the blood pressure of the patient is raised, you should start treatment with antihypertensive agents. What we have discussed in last slides, this is the summary of that entities. You can see in the first column, you can see the description of the chest pain, while past medical history or emergency subsequently. And if you go over this one pictorial slide, you can cover all deadly causes of chest pain. Take-home message, there are many causes of chest pain, which range from very benign to immediately life-threatening. The most important diagnostic step is to rule out life-threatening conditions. The most important tool you have is your history and physical examination. What would help you is ECG and chest X-ray. You shouldn't miss the life-threatening causes when patient arrive to you in emergency department. Not underuse your tools, not overuse your tools. As we belong to a very poor health system, so we have to keep in mind that we don't overuse our resources. While patient may doesn't have any diagnosis, and end of the day, what you can, and you ruled out all 4 or all 6 deadly causes of the chest pain, what you can discharge after, then you have to keep that patient for next 24 hours on telemetry monitoring in emergency department. And by if the pain gets relieved or it doesn't deteriorate, you can discharge it with non-cardiac chest pain, with the diagnosis of non-cardiac chest pain, non-specific non-cardiac chest pain. Thank you. This is my email address, hashim_s85@hotmail.com. Those who joined our session lately, I recently joined cardiology department as an assistant professor of cardiology. Hope to see you soon, inshallah, after this pandemic. Thank you. Hello.
Doctor, do you have any question answers?
Yes.
Just click the chat icon there.
If
Okay, it's okay. We can end the session now, right?
Okay.
Thank you.
You're welcome. You're welcome. Take care. Assalamu alaikum.